So we have a panel to start our afternoon session, and I'm just going to briefly introduce everybody and then hand it over to Roger, who will be starting the session. So I think everybody knows Dr. Roger Strasser, who is the Dean at the Northern Ontario School of Medicine. I know that. So that's right. Okay, our next speaker is Dawn Mitchell, sitting right here, and Dawn has been a member of the North Simcoe Muskoka Lynn Board of Directors from 2010 to 2015, and has been a council chair for the Muskoka and Area Health System Transformation Project. Next to that is Jessica. Jessica is the Director of Systems Strategy and Innovation for the Northwest Lynn. Then we have Paul Preston, who's Vice President Clinical for the Northeast Lynn. And then at the end, I know we have Neil Walker, who's Vice President System Transformation for the North Simcoe Muskoka Lynn. Okay, so I'll hand you over there.
Thank you very much. So welcome everyone to this first session this afternoon in the Symposium. As you can see, our group has decided that we're going to present sitting down to emphasize that we're here to interact with you and encourage you to speak. And as I said in my opening remarks for the whole symposium, we want this to be interactive, and we are going to discipline ourselves to keep our remarks brief, so there's plenty of time for discussion. Your round tables, we may even allow a little time for you to have a discussion at your table to generate comments and questions to raise with the group. So brief presentations, and then lots of interactive discussion, and then an opportunity for each of the presenters to just make some closing remarks. We've deliberately chosen not to have PowerPoint slides, so you actually have to listen to what we say, but it gives us the opportunity to be a bit more flexible in terms of connecting what we say to each other, and also what we heard this morning. So this session, the topic is about challenges of capacity and development for health system sustainability, and then a sort of follow-on, what can universities, colleges and other groups do to contribute to increasing capacity. So that's what this session is about. It's about sustainability. And actually that's health service models, rural health service models, and sustainability is a research interest of mine. I'm going to make a few opening remarks, and then we'll work our way through the panel. So I would say from research that I've undertaken and what I've seen elsewhere in the literature, the health service models that work best in rural, remote, Indigenous communities are ones that are developed in the community, for the community, by the community. And I think that approach is certainly consistent with what you heard this morning in the presentations for the Rural Health Hubs as a local initiative and coming to the table. And in fact, the coming to the table message, I think, is also one about context and developing models within the context. And when you come to the table, listening and learning and taking the lead from those who are at the table. And I think that's a key to the success when it comes to sustainable services. And it's important to recognise that those who provide healthcare in remote, rural, Indigenous communities are the providers of care. They are rural practitioners, and in my observation, rural practitioners, when you compare rural practitioners to the metropolitan counterparts, they provide a wider range of services and carry a higher level of clinical responsibility in relative professional isolation. Wider range of services, higher level of clinical responsibility in relative professional isolation. And that's true whether you're talking about doctors and doctors in different medical specialties, family doctors and surgeons and paediatricians. It's also true if you're talking about other members of the health workforce, so nurses and pharmacists and so on. So rural practitioners are the providers of care in remote, rural, Indigenous communities. And the role of the specialty services and service providers is to support that. I've seen too many examples of specialty services that drop in and drop out of communities. You know, the psychiatrist or the psychiatric nurse is there for their once every 2 weeks visit, and the psychiatric emergency happens just after they left. Or they see a number of patients or clients and with no communication to the local providers, and then that adds to difficulty and confusion for the people in the community. So the role of the specialty service is actually support the local provider, to be true consultants, and that includes in co-managing clinical problems and providing education and being a true consulting service. Some years ago, talking about sustainability, I was involved in a study in Australia where we looked at what the factors that contribute to sustainable services in health services in remote and rural communities, and we did 28 in-depth studies, and we looked at communities where the services were doing well and communities where the services weren't doing so well, and we found that there were 3 key contributors to sustainability in those in the communities that were doing well. It's kind of like it's a 3-legged stool, and you need strength in all 3 legs of the stool for a sustainable health service. So you need strength in the local health service agency, hospital, and or whatever it is. In our context, that might be a hospital or health service, and supported by the LIN, the Local Health Integration Network. You need also a strong strength amongst the healthcare providers, the doctors and nurses, nurse practitioners, whoever the local providers are. So those 2 you might have thought about you need for sustainability. The third contributor to sustainable health services we found was community. So what we found was that the models, the health services that were doing best in remote rural communities, there was active community participation in the development and delivery of the health service. And it was really that knowledge coming then to Northern Ontario and drawing on the movement that I mentioned, the advocacy from communities to set up the school, that was the basis for the community engagement that we have at NOSM, and if there's an opportunity, I'll say a bit more about that and how we do that in Northern Ontario. So active community participation really is a strong contributor to success when you're talking about sustainable health services in remote, rural and Indigenous communities. They're my introductory remarks. I'm now going to hand the ball over and for Don to pick up the theme. Don.
So my name is Don Mitchell, and I've had the pleasure of being the chair of a planning council in the Muskoka area for the last year. And the council is called Muskoka and Area Health System Transformation. And it was a project set up by the North Simcoe Muskoka LIN to try and implement the recommendations, or if you would, the research that you people work on, and how do we actually make some of these things come alive in the community. So the LIN gave us a challenge. They said, get your people together, make it a community engagement endeavor, and we only have 4 things that we want from you. The first thing is we want a health and healthcare delivery system framework that is specific to Muskoka and area. That was pretty straightforward. The second one was we want an implementation plan for that. Okay, kind of makes sense. When you pull everything together, we also want to know how you plan to govern it. And last but not least, it has to be a sustainable system. So no little challenge put out to the community, but certainly one that the community started to work on. And so we went out and canvassed a group, got them together, 60 people. Out of the 60 people, 58 were all from Muskoka and area. We had 2 outside people that were engaged in the initiative. They got together every Thursday morning from 8 to 11 and talked about how to make things better in Muskoka. So we started to land on a couple of things, but the first thing we needed to do was to have a goal. And the goal was very straightforward: better health, better care, better provider experience, and last but not least, better value. So how do we actually make that come about? So Lou talked about the hospital hub model, rural hospital hub model. We looked at that model. We looked at the Ontario College of Family Physicians, their patient medical home model, and we looked at what was called the Price-Baker Report, and took all three of those and cherry-picked the best things out of them that we could try to apply in Muskoka. And then the fun started. How do we really make that come about? And so if you start to think about it, we got into a variety of different discussions looking at the continuum of care. But in this particular case, what we were asked to talk about is challenges. And so challenges for developing the system, first of all, many people don't have a common understanding of what a system is about. So in other words, systems thinking. We have people that know their individual places, their individual roles, but how that all plays out across the continuum of care, that is a challenge, and one that we're continuing to address. The next challenge is the whole concept of collective impact. And, so when you want to make a change, how do you go about doing that? And it's really interesting when you start to bring a group of clinicians in to chat about how are you going to start a collective impact movement. A lot of them obviously had a bit of a ponder around the steps involved. And something as simple as trying to establish a common agenda amongst a group of practitioners, providers, community members, persons with lived-in experience can be really quite challenging. And I guess the third thing from a challenge that we found and faced was certainly the move or the initiative of the local municipality members, people starting to get involved in a more fulsome discussion around health and healthcare delivery within the community. So those are just three of many challenges that we came across in our work.
So thank you. I'm excited to be part of the panel in terms of sharing what the Northwest LHIN in our mandate to plan, fund, and integrate services is doing to address some of the capacity challenges and access challenges that we have. And I'm going to focus on just two specific areas. So how we're using technology specifically and innovative solutions to begin to address some of the capacity and access challenges. And the other piece is sharing a little bit of information around what we're doing to engage local communities, local providers to better understand capacity and build some sustainable solutions around that. The other piece that underpins all of this, which I won't touch on more than just to say our system strategy for transformation is really our health services blueprint, which Lou actually spoke to in the previous presentation, and how we're looking to better organize services at the local, district, and regional levels to really get at better access and connection in that way. And at the base of that is the work that we're doing around the local health hub work as well. So obviously in the Northwest LHIN, we have significant challenges in terms of geography. So we represent a population that covers about 450,000 square kilometers, and a population of about 235,000. 21.5% of our population is Aboriginal, and we have obviously huge geography access challenges layered on top of that, high rates of preventable disease, challenges with recruitment to northern communities, and finite resources. So there's a huge challenge there. And just getting into the first example around how we're utilizing technology and innovative solutions, I'll share one example of one of the programs, which is around our Regional Critical Care Response Program, which is really an innovative e-health strategy that leverages the OTN technology to provide 24-hour access to critical care specialty services within our only level 3 critical care hospital, which is the Thunder Bay Regional Health Sciences Center. So we have 11 of our community emergency departments, as well as 4 of our remote nursing stations that have access to this specialty care within Thunder Bay. So supporting them to support acutely ill patients as close to home as possible, and being able to prioritize those who are critically ill to be able to transfer them to a tertiary center when needed. But really being able to support, as Dr. Strasser said, in terms of those primary care physicians or the physicians in the community, to be able to support them through specialty services where they are and providing care for patients as close to home as possible. And just building on that thread of technology, the other pieces that we're seeing increased use of are solutions such as e-consult, so around teledermatology, telepsychiatry, and we still have lots of work to do in that area, but just some ways that we're looking at improving access and building capacity within the communities. And the other piece that I'll touch on briefly is the work that we're doing around capacity planning and the engagement of physicians around primary care, so physicians and NPs specifically. So we've been working over the past 2 months to engage directly with the communities and with the physicians to understand what primary care capacity looks like. And exactly to the point that you made earlier, we know that primary care physicians and physicians in general in the North are doing much more than just primary care. They're covering ED, they're doing obstetrics, inpatient, anesthesia, large amounts of work that go beyond just community-based primary care. So really trying to understand what that looks like so that we can plan better and come up with sustainable solutions to address that. So solutions in the short term around how we can leverage interprofessional care teams, thinking about traditional healing and building capacity in that sense, but then in the longer term, sort of forging stronger partnerships between the LHIN from a planning perspective, Health Force Ontario from supporting recruitment, and NOSM obviously from the medical learning and education piece as well. So those are just some examples that I'll touch on, and I'll end there and pass it over.
Thanks, Jessica. Just one, we have to guard against use of abbreviations or acronyms without explaining them. OTN stands for Ontario Telemedicine Network, and I'm guessing at least some people didn't know that, but that network, which is now a province-wide network, started in Northern Ontario's North Network. So there's been innovative use of communication information technology for close to 2 decades now in Northern Ontario, and helping to enhance access and quality of care in the small, remote, rural communities. Okay, over to Paul.
Hello. Sorry, it's working. Sorry. So I'm a doc. I graduated from U of T in 1985. I'm a Northern Ontario kid. I've been on NOSM faculty for 10 years as an associate professor. And so I've been practicing for 30 years. And the point I want to make is I've witnessed a culture shift over the period of time in the new graduates. When I was a rookie, we took every extra shift we could to try and pay off our student debt and maybe even then work on our mortgages. And I haven't been able to give away a walk-in shift for 15 years. The rookies aren't interested. And talking to the new grads, they have an evolved sense of values, a much more balanced lifestyle is a high profile to them, and wasn't something I even considered. So many of them want to spend time with their families, be healthier than I was, and live a healthier life. And they were amazingly debt tolerant, being a generation away from any kind of a normal interest rate. So they don't seem to be in a hurry to pay off their loans, and work Saturday walk-in clinics for the old guys like me. And they really want to be in the teams, and they want to decrease that professional isolation that Roger described being a characteristic of a rural and northern physician. And they want to be obviously in an EMR and connected in a turnkey operation. So I see that as sort of the culture that we have to really figure into our strategies, because as you know, culture eats strategy for breakfast, as Peter Drucker said. And every strategy we come up with will fall flat if it doesn't address that culture, as well as the culture of the communities that we serve. Some of the recruiters for the small towns have shared with me comments from residents that were trained there, such as, where is the sushi bar? The nearest one would be about 6 hours away. It's been a great experience. I learned a lot, but I'd never work and live here. So I think that the answer will lie in efforts like rural health hubs, where in the North Shore Rural Health Hub, which takes a collection of several communities spanned across 165 kilometers, mostly with groups of 1 or 2 docs, although there's a family health team with 5. So there's docs that they're doing 1 and 2 call, and none of them with the scale to really have enough allied health support to generate any kind of support in their practices or any admin support for most of those practices. So without the admin support, you don't get to write proposals to get more admin support, so you don't get the admin support that you would get if you could write proposals. So there's a lot of that, I think, has gone on in our communities without any mechanism to get more. The people that can write proposals got proposals. So the answer to that is, the system organizing the communities, perhaps clustering them into a rural health hub if they're too small on their own for any scale to have the allied health support and the administrative support. They need to do quality improvement and work with the system. So that has to be funded into the system design. And so we are going around to all of our communities, identifying them, bringing them together. If they're the benefit of the North is that many of the communities are separated very easily geographically, so it's not hard to figure it out. And but many of them are clustered together, and individually it'd be hard to generate a hub of when there's only like 800 people and part-time docs. So, but together collectively they can have the scale that allows efficiencies and share staff, and staff can move amongst the communities, and rather than the patients have to drive out of their own community for primary care, which kind of defeats the purpose of having primary care. The other thing I've seen work in some of the communities is delinking emerge shifts from primary care. So that's, and so some of the places, for example, close to Sault Ste. Marie, the younger emerge docs in Sault Ste. Marie come out and do the alternate funding arrangement ER shifts for the whole weekend, and allows the primary care docs not to have to do them. So it's extended the career of some of the older docs who become intolerant, like I am, of losing their night's sleep, and it allows some of the docs who don't want to work nights and weekends to practice primary care during the day. So these are some of the options I think that really address the new cultural shift that I'm seeing. So I'll stop there.
Thanks, Paul. I'm going to pick up on a couple of themes that you mentioned, talking about students or residents coming to small communities and saying, well, I had a great experience, but I wouldn't want to live there. And to take the opportunity to tell you a little bit more about the situation with NOSM, with Northern Ontario School of Medicine. We actually have a selection admissions process that favours applicants who come from Northern Ontario. In fact, we aim to reflect the population distribution of Northern Ontario in each class, and we've been quite successful. 92% of our medical students have grown up in Northern Ontario, and the other 8% come from remote and rural parts of the rest of Canada. This year's first year class started a few weeks ago. 45% of the students come from remote and rural community backgrounds. That's actually higher than the proportion for Northern Ontario if you take out the 5 larger population centres and say the rest is rural and remote. This year we have 11% of the first year class are Indigenous students. That's close to the demographics in Northern Ontario, and we have 22% Francophone students. So we reflect the population distribution. As I mentioned earlier, then a lot of the clinical learning for our students is actually in those communities. So they're learning in context and preparing to practice in Northern Ontario communities. So it's a different message that you get from NOSM students and residents about the potential for practicing in these communities. But that's not the whole story. And then there's the issue of the expectations that as Paul mentioned, the expectations of recent graduates in terms of the mix practice style and lifestyle is quite different from the more senior physicians like Paul and myself and so that's something else that we need to take into account when we're looking at sustainability of health services. And we also need to take into account the expectations of the community writ large of physicians is changing as well. So, back when Paul started in practice, there was no vice president clinical for the LIN. So there's an expectation that physicians are involved in hospital and health services, in the LINs, in all kinds of other roles, and now with Northern Ontario School of Medicine as academics in teaching and research as well. And so when they're putting time into these activities, they're they're not spending so much time in patient care and clinical service. And so that adds to the sense of the need that we have in expanding and developing the workforce in Northern Ontario, and it's similar in other remote, rural and Indigenous community settings. So that's just fleshing out for the context in Northern Ontario, what Paul said, and now I'm going to hand over to Neil.
Great, thanks very much, and it's a pleasure to be here today. There's so many things I could say, but I will stick to my 5 minutes. Just a bit of context. I'm a graduate from the University of Toronto program. Started my career in academic health science centers, so Hospital for Sick Children, University Hospital in Saskatoon. And I really learned about health when I went to Northern Manitoba and had the experience in rural and northern health. So I'm going to give you a bit of context about the role that I had there and talk about capacity and development, and also in the context of where I am now as Vice President of System Transformation in North Simcoe Muskoka Lynn. So in terms of my response, I want to share the lessons I've learned in the 30-some years I've been in the industry, as I said, in Northern Manitoba in my current role. What I've learned and try to continue to practice involves 3 beautifully simple but very complex words: partnership, partnership, and partnership. And I'll talk to you a little bit about Northern Manitoba to start off with. When I arrived there, regional health authorities were just being established, so lots of chaos in terms of change. And we did not have capacity on the primary health care side of things. So because of my experience at the University of Toronto as well as University of Saskatchewan, I was comfortable in reaching out to the University of Manitoba, who had historically had a relationship with the regional center in Northern Manitoba, but that relationship had dissipated and fallen apart. So by reaching out to them to work with me to recruit faculty to Northern Manitoba, we were able to start to create capacity. Concurrently, we did extensive recruitment in terms of primary care physicians. In a very short period of time, 2 years, recruited over 30 new practitioners to Northern Manitoba, so that we at least had the foundation to start to develop a sustainable health delivery system. Within the context of Northern Manitoba, again, very remote, the road ends at Thompson, Manitoba, had 14 First Nation communities within our regional boundaries north of the 53rd. And the challenges that were alluded to in terms of the federal versus provincial issues of funding and who provided primary care were in the forefront. And so in terms of working with our Indigenous communities, I really love the term of being invited to the table. We worked very closely, our Aboriginal liaison individual from our region, along with our senior leadership, to be invited to the tables in the respective communities. And we went and visited, worked, sought to understand, and then looked at partnerships in terms of developing how we could move forward collectively to stabilize and then begin enhancing the health of the residents of Burntwood region at that time. So that was really my experience there. Don alluded to some of the work that we're doing in terms of North Simcoe Muskoka, in terms of developing capacity and meeting our communities, getting community involvement in planning. The example that Don provided is one where our regions are moving forward to look at community involvement. And again, community is a very complex word. You have various communities that you need to draw on. And we have another example of a community in the Collingwood, South Georgian Bay area that has taken a bit of a different approach, but is arriving at a collective to actually developing integrated health delivery systems by, again, having the players around the table to move forward to develop and enhance and create a sustainable health delivery system, trying to take inefficiencies out of the system by decreasing duplication, working collectively to leverage the scope of all of the practitioners within the system, and then look at strategies to recruit and retain additional staff. Again, they're working with the various academic centers as well, because all of our LIN sees the benefit of working with our academic centers to, number one, recruit and retain, but also to use leading practice or evidence to drive the work that we're doing as we develop a sustainable health system. So I'll stop there.
Yes, well, thank you very much. Partnership, partnership, partnership. That's the message, coming to the table and listening respectfully. Northern Ontario School of Medicine has been in place for just 12 years, and already really the situation in Northern Ontario in terms of access to healthcare is quite remarkably improved. If you look at the graduates from our MD program who've done their residency in Northern Ontario, 94% of them are practicing in Northern Ontario, including a third, 33% in the smaller remote rural communities. Amongst our graduates are Indigenous physicians who are now providing care to their own people in Northern Ontario communities. So there's certainly some activities in Northern Ontario that are starting to make a difference, and this difference wouldn't be happening without the partnerships and collaborations that the school has with the communities, with the health services, the healthcare providers, and many others in the north. So you've heard, and each of the speakers has behaved well in terms of sticking to their 5 minutes. This means that you have 5 minutes, and it's a time for you to form a partnership with the people at your table to have a discussion about the issues you've heard and your ideas about sustainability of health services in remote rural Indigenous communities, and with the idea that then from your table you can bring to the larger group questions and comments so we can have a discussion involving everybody. I guess those of you who are with us through the live web streaming, I don't know if you can talk to each other, but you can talk to yourselves, and we're certainly looking forward to your contribution to the conversation as well. So now's your 5 minutes to have a partnership discussion at your table, and then we'll have a wider discussion.